Hello, and welcome to our webinar guests today for the Interior Health Research Week, our final day, our Seniors Day. I'm Michelle Smith, Regional Practice Lead for Research Quality and Knowledge Mobilization for Long-Term Care, Seniors Care in the Research Department at Interior Health. And also facilitating today with me is Paula Morrison, the Research Coordinator of Research Quality and Knowledge Mobilization, same Long-Term Care, Seniors Care, and the Research Department at Interior Health. And as we just build a few minutes, just think everyone's just making sure we see everyone's contact audio going up. And then we'll pass to Paula. Oh, Juanita can't hear. Can you check, Lindsay?
I can hear okay.
So can I?
No, she fixed it.
Oh.
Okay. So Paula, I'll move on. I can switch over to you if you'd like to do our.
Okay. Thank you. Thank you for attending. My name is Paula Morrison. I'm grateful to be one of the hosts with Michelle, with Lindsay, and with Kim. Grateful to work with such a great group of people with this research committee, Research Week committee, and as a research coordinator with Interior Health, focusing on the quality of life for residents, care teams, and long-term care and seniors care. I'm honored to be in this space. I'm actually of Tahltan ancestry. I'm an Irish descent. I'm located in the traditional and ancestral and unceded territory of the Silks Nation. I'm grateful to be here. Today happens to be in our community Tahltan Day. We made a declaration in 1910 declaring our space in the world as Tahltans, and that's northern BC. So I'm long ways from home. I walk in a lot of worlds, and I really appreciate being from that northern space. And I'm proud of my heritage and proud of the strength of Tahltan people. I'm grateful to be on the lands near Okanagan Lake and welcome for you to share the names of the traditional and ancestral spaces and lands that you are gathered on in the chat box. If you don't know the name, know that you can always find that, because I know the names have changed and can sometimes challenge us linguistically, but you can find those names on the nativeland.ca. So thank you. Thank you and welcome. Thank you for coming and taking time with us today. We appreciate it. And I know it's a heavy time in some spaces in these spaces in the world and in the world. I hope we find some lightness today and be in community and moving forward together. So thank you.
Thank you, Paula. So we will move forward, and we have a lovely group of people today and a tight timeline. So we'll get you started with Juanita. So in the Interior Health Research Week 2023 is hosted in partnership by the Interior Health Research Department, the BC Support Interior Center, and the Rural Coordination Center at BC. This year we planned 4 days, remarkable dialogues and presentations that aspire to improve the health and well-being of our communities at home and beyond. And today is our final session, Seniors Health, where teams will present on research and quality projects to improve the quality of life for older and aging population throughout the interior and beyond. So we thank you for attending this today, and we look forward to hearing from everyone. So some of our housekeeping just to take note of. So Zoom view, feel free to change your view to speaker mode for the best experience for these sessions by clicking on view at the top right corner of your screen. Closed captioning, the closed captioning box can be moved to your preferred place by clicking and dragging it to where you would like. To turn off closed captioning, select hide caption box button, on the menu bar. For questions, please type questions or comments for the speakers into the chat box as we go along during the presentation, and we will read them to the speakers, and they can answer for if anything else happens. If we don't reach them all in time, we can follow up with you can connect directly with them, or we can follow up in the research department with the speakers. research@interiorhealth.ca is the email you can use. For the recordings, we are recording the sessions for share later, and they'll also be sent directly to the registration email that you use to register for this. And speakers, I'll skip that for now. So today's first session is presenter Juanita-Dawne Bacsu, Assistant Professor in School of Nursing and Tier 2 Canada Research Chair in Nursing and Population Health for Thompson Rivers University. And the presentation today is using Twitter to examine vaccine-related ageism during the COVID-19 pandemic. I'll pass on to you.
Perfect. Thank you. Thanks, Michelle. It's great to be here today and have the opportunity to speak during Interior Health Research Week. So thank you so much for having me. And Paula, thank you so much for that great introduction. All right, so before I get started, I just want to acknowledge my research team. The work that I do, I couldn't be done alone. So I'd just like to recognize that I had a national team of researchers from the Canadian Consortium on Neurodegeneration and Aging, our Stigma and Social Inclusion work group that helped me really complete all of this work. And so I couldn't have done this study without them. There was so much data to analyze. And so it was just so great to have everyone's collaboration on this project. All right, so here is a brief overview of my presentation and some of the topics that I'll be covering over the next 20 minutes or so. I'll provide a bit of background on vaccine-related ageism during the pandemic. Then I'll discuss our Twitter research methods, and then talk about our findings and the contributing factors of ageism during COVID-19. And then I'll wrap up with some strategies for moving forward. So during the rollout of COVID-19 vaccines, older adults were often prioritized for inoculation in efforts to reduce COVID-19 related deaths and mortality. However, this prioritization may have contributed to ageism, particularly with the limited supply of the initial COVID-19 vaccines. So what is ageism? Ageism refers to how we think, feel, and act towards others based on one's perceived age. Ageism can include negative stereotypes, prejudice, and discrimination that is directed towards people merely on the basis of their perceived age. Some examples of ageism include having fixed ideas and making judgments about people, or ignoring and treating people as inferior or incompetent strictly on the basis of their age. So why is ageism so important? Ageism can lead to social isolation, depression, anxiety, decreased quality of life, elder abuse, and research shows that it has contributed to limited access to health information, medical services, and treatment options during the COVID-19 pandemic. Despite this knowledge, little discussion focuses on understanding vaccine-related ageism in the context of the pandemic. Now, with over 368 million monthly users, Twitter has become a widely used platform to share beliefs, concerns, myths, and even opinions on COVID-19 vaccines and ageism. So understanding ageism and age-related vaccine sentiments on social media are important to supporting COVID-19 vaccine campaigns. For example, examining vaccine-related ageism on Twitter may help public health officials, community leaders, policymakers, and healthcare practitioners address vaccination myths, concerns, and false information related to age. And so our research objective was to examine vaccine-related ageism during COVID-19 on social media to inform future vaccination campaigns, awareness strategies, and policies. For our methods, we use the Twint application in Python to collect relevant tweets on Twitter from December 2020 to December 2021. Once the data was cleaned using filters, the existing 1,369 tweets were analyzed by a group of coders. We had each tweet coded to ensure intercoder reliability. We used thematic analysis to identify the main themes in our data. And on the side of my screen, you can just see a little picture. There's so much cleaning of the data that happens with these infodemiology studies. We always start off with such a huge amount. You can see we started off with 5,000 tweets over, and by the time we got done, our relevant tweets really got narrowed down to the 1,369. Now, based on our research, 4 main themes emerged. The first theme was blame and aggression. For example, some tweets expressed blame, extreme anger, and hate speech towards older adults. Many of these aggressive tweets argued that older adults should die in the pandemic. A Twitter user stated, "Don't forget the outbreaks were caused by entitled boomers who refused to get the vaccine offered and were waiting for their luxury vaccine of choice. Time to let it rip now for people being selfish. Hashtag selfish boomers, hashtag COVID, hashtag let it rip." Another user stated, "Wish COVID-19 could be modified such that it would only wipe off boomers regardless of vaccination." Now, these aggressive tweets are extremely problematic as they convey violent messaging that may normalize harm and violence against older adults. Consequently, victim blaming on social media platforms such as Twitter may exacerbate discriminatory behaviors and action that may increase older adults' risk for abuse and harm, especially during the pandemic. Another theme that we heard a lot of was misinformation and mocking content. In many tweets, older adults were portrayed as incompetent, misinformed, naive, or unaware, and in turn described as endangering others and themselves due to their belief in falsehoods or conspiracy theories about COVID-19. Some tweets propagated ageism and focused on misinformation about vaccines, either accusing older adults of spreading false information or believing false information from the media. This theme is illustrated in the following tweets. Fun fact, your boomer parents are now watching 6+ hours a day of YouTube videos claiming that COVID vaccines are actually hookworms being injected to modify your DNA with nanotechnology. Another user stated, all boomers do on Twitter is spread COVID misinformation or blame young people for the state of things while refusing to get the vaccine young people can't have. Now, another theme identified was ageist political slander and insults that fueled ageism and intergenerational content. Many of these tweets used ageist language to direct insults at political leaders. A Twitter user stated, think about Biden's policy when considering his COVID mask vaccine policies. This dementia-addled old coot has no idea what ramifications his wholly partisan political actions can, have, will cause. Another Twitter user noted, can you imagine if Biden wasn't handed 3 vaccines on a silver platter? The senile old man can't even find the entrance to the White House. How is he supposed to be in charge of protecting the American people from COVID? Now, issues of vaccine hesitancy and perceived structural ageism in vaccine-related policies were also emergent throughout the tweets. For example, although many jurisdictions used vaccine guidelines that were based on the best science at the time, there was a perception that a less preferred vaccine was being offered to older adults because they were viewed somehow as being less than or more expendable than younger generations. A Twitter user wrote, is it just me? Is this ageism that is occurring over the rollout of the COVID vaccine? Second rate AZ for oldies, don't care if you die, top line Pfizer for the rest because they will pay tax longer. Another Twitter user noted, give all us oldies the cheapest AZ COVID vaccine, offer youngsters a more expensive choice. Oldies have rights. Now, some tweets advocated for more accessibility and measures to support older adults during the pandemic. In particular, many tweets identified that the COVID-19 online booking systems were problematic for older adults who had limited technological expertise or no access to computers. A Twitter user stated, "The COVID vaccine booking system process is awful and not friendly for older adults. We need to have a much better system." Another Twitter user noted, "Spending my day signing up older adults for the COVID-19 vaccine. My 90-year-old neighbor told me she doesn't have a computer and can't stand in line, enacting my personal time off to take her. Worry not." Now, based on our findings, we found that understanding COVID-19 vaccine-related ageism on social media really provides pertinent insight to inform future vaccination campaigns, awareness strategies, and policies. Our study identified issues of hate speech, false information, and ageist political insults that are contributing to ageism and intergenerational conflict. Some older adults also described issues of mistrust towards different vaccination brands related to fears of structural ageism in the COVID-19 vaccine rollout. These findings suggest that ageism may have contributed to fear and COVID-19 vaccine hesitancy towards different vaccine brands. Now, a subset of tweets also advocated for improved COVID-19 policies and vaccine booking systems to be more accessible for older adults. And so moving forward, we found that Twitter was a useful tool for identifying issues of vaccine-related ageism and ageist policies impacting older adults during the COVID-19 pandemic. And based on our study's findings, we believe that further research and targeted awareness campaigns are required to address COVID-19 vaccine misinformation, counter aggressive ageist content, and support intergenerational unity during the COVID-19 pandemic and beyond. Before I end and close here, I'd like to recognize and thank my funders for supporting this research. And I'll just end with my email here if there's any questions.
Thank you, Juanita. And you can type any questions into the chat, and Paula's monitoring them. We'll read them out as we go.
I have a question. I'm wondering how you managed to compart, maybe it's not the right word, but how did you manage the emotion of some of those tweets? Because it's a lot coming at you, even just the ones you highlighted, and you saw 4,000 and boiled it down to 1,300, I'm thinking. But
oh, it's definitely, that's such a great question. It's such a heavy process. And that's what I love about working with our team. We work with a large team, and we have a lot of chance and time we take for team debriefing, because we realize that a lot of these tweets, they're very raw. They can be very heavy and dense, and some of the sentiments, like there is right out hate speech happening. And so, you know, just having that team support and being able to kind of talk through what we were seeing, I think that was very helpful for the group and the team.
Thank you. Thank you. I'm glad you're doing the work, but that's hard work to be present for that. So, and if anybody needs space to step away and process, then know that you can do that. Or if you need to turn your screen off, we didn't mention that earlier too, because it can be heavy, but I appreciate the work. Thank you for sharing. And I think there's a question. I'm just going to take a look. So a question from Callie. She's just wondering, what is the average age for Twitter users? Do you know?
For sure. So we're really lucky, actually. I don't think we could publish our research as much as we do if we weren't able to kind of provide the statistics for our users. So we do know that there are users across the age range. There's less when you get up into the older adults. I'd have to go back to check my notes, but every time we publish, we provide the statistics to show, you know, the gender, that there is a balance between men and women, and also across different age groups. I believe I shouldn't even quote here because I'm not sure. I'd have to go back and check, but I know it is across age ranges. So that's a great question, though.
I actually don't use it, so I'm curious because I really manage how much I take in, because I can't take it all in myself. But and we have another question. Thank you for that from Barb. What is your next study? Oh, what is your next study from Barb? I have another question too. One more.
Oh, so that's a great question. The next study that we're actually looking at is looking at Alzheimer's Awareness Month, the global month worldwide across the world, and seeing what's happening to improve awareness of dementia and Alzheimer's disease. And so we're hoping from there we can learn some really strength-based solutions and strategies that we can bring back and look at the Canadian example of how can we improve and enhance our awareness, communication towards Alzheimer's disease and dementia. And so that's our next study. We did actually complete a Canadian focus study looking at Alzheimer's awareness during the month. In Canada, I believe it's in January. And so we focused on those tweets. And then after that, we were like, okay, this is great, but now let's see what's happening globally. I know usually, I think it's in the month of September that global tweets happen, the Global Awareness Month. And you see a lot of celebrities and champions talking. And so I feel like there's going to be, I don't know, some really interesting kind of takeaways there from that study that we can like bring back here to Canada. So I'm looking forward to it. Can't wait to get started. Thank you for the question.
Interesting. That's super interesting, that global perspective. So there's two more, and then we'll move on to our next presentation and take any questions that you have further to the research@interiorhealth.ca email. But what surprised you most about these findings? Kim's wondering.
I think just the sheer rawness of them and just kind of what people are willing to put out on social media. It's kind of surprising. I do a lot of community-based work where I do interviews and focus groups with people. And then sometimes when you go over to social media, it just kind of blows you away that, you know, people would actually kind of write. It's just so, you know, kind of raw and thoughtless. It seems like there's almost a loss of emotion sometimes when people are posting on social media. And I think that's why we need to really focus our work there with awareness campaigns and with getting education and awareness out, just to try and make a difference there, because I feel like there's so much room for impact, to have a positive impact and really, you know, make that message strong, that people living with dementia, you know, they are people, they have quality of lives. There's so much homogenization and stereotyping that happens online. And it's important for people to know that people living with dementia, you know, they're across multiple different stages. The disease isn't a linear process. Not everyone experiences it the same way. And too often we see media focus on the end of life stage. And so there's this kind of stereotype out there that as soon as you receive a diagnosis of dementia, your life is over. And so I think there's just so much work that we can do to kind of spread the word that you can still for sure live a meaningful life living with dementia. And I think that's so important.
Thank you. That's a message of hope for sure, because I think we need that, especially if in that population for sure, and the families too, because they're the ones who would be absorbing some of, I think, that rawness. Just wondering if the last question, if you, to your knowledge, there are any community guidelines or tactics targeted towards these hate speech comments on Twitter. Are you aware of any verbiage or guidelines that?
Twitter is working or was working on implementing guidelines for hate speech, and they try to, I think, filter it out. I haven't checked recently, but I think it's hard for them to catch everything. But I think more work needs to be done there, 110%, for, you know what I mean, to make sure that this isn't happening, because it's not just, you know, older adults being targeted. There's hate speech across multiple different groups. And so I think the more that they can do to try and filter that out, the better.
Yeah, that's so true. Thank you for sharing, Juanita.
Thank you so much for having me.
Thank you, Anita. We have our next presenters are Bobbi-Jo Basarab, Community Health Worker in Interior Health, Darien Miyata, Registered Nurse, Interior Health, Mary Kjorven, Clinical Nurse Specialist, Gerontology, Interior Health, and Jennifer Stieda, Improvement Consultant, Interior Health. And their title is Recruiting and Retaining Community Health Workers, Creating an Engagement and Education Framework with the Community Health Workers for Community Health Workers. I'll move it over to you.
Can you see the screen?
Yes, looks good.
Perfect. Okay, we can get started. Bobbi-Jo? Just wondering if you might be on mute, Bobbi-Jo.
Looks like she's asking somebody how to get off mute. Just hover over the bottom of your screen, Bobbi-Jo. Yeah.
Thank you very much. Sorry, I'm not usually on this computer. I apologize.
That's okay.
Good afternoon, everybody. My name is Bobbi-Jo Basarab, and I am a community health worker from Golden, BC, and I'm honored to be invited to present today. My co-presenters are Mary Kjorven, who works as a regional clinical nurse specialist in gerontology, Jennifer Stieda, who works as an improvement consultant, and Darien Miyata, who is a registered nurse who is on maternity leave at the moment. And while she's not able to present today, as babies do not always adhere to schedules, I believe that she may be attending. We are all employed at Interior Health. I am Coast Salish from the West Coast. I'm from the Halitzum Holkaminum and would like to acknowledge the traditional territories where we live, learn, and work together.
So to enter in, we've all known for a long time that Canadians' population is aging. We also know that overwhelmingly older adults wish to age in their own homes. And by overwhelmingly, we mean almost 100% of surveyed Canadians 65 years and older plan to live in their own homes as long as possible. At the same time, community dwelling seniors are living with more complex conditions and comorbidities. Not only do they need to learn to manage these complex conditions at home, they must also continue to perform their activities of daily living, like bathing, dressing, and preparing meals. Some have family members or friends who can step in to help, but many older adults rely on formal community support services to function at home. By and large, community health workers, and hereby in this presentation, we'll refer to community health workers as CHWs, provide this care and are key to a health system which aligns with the goals of its citizens.
Community health workers are referred to by a number of terms, including personal support workers, home health aides, home care assistants, community care aides, home care aides, home support workers, and home care workers. Every year, CHWs provide over 8.5 million hours of home support to British Columbians in need. Their training follows a standardized curriculum. The program lengths vary, but are about a year long and include 2 practicums. 210 hours in long-term care setting and only 60 hours in home or community settings. This illustrates part of the problem, a heavier training focus on facility settings as opposed to the community settings, which is where clients prefer to receive their care. Recruitment and retention of CHWs is one of the greatest challenges in home and community care staffing. Effective retention is crucial as labor markets forecasters predict that CHW positions will be amongst the most difficult to fill as demand rises. There's plenty of evidence about improved compensation and better staffing structures contributing to better retention. While these strategies are important, they don't necessarily promote a meaningful and satisfying work experience. The recurrent loss of CHWs impacts all levels of healthcare. On the micro level, 51% of home support clients are at a high to very high risk of long-term care admission. CHW shortages result in care shortages and increase this risk. CHW turnover has been linked to increased risk of pressure ulcers, contractures, injuries, emergency department visits, and hospitalizations in home support clients. At the meso level, nurses create individualized home support based on the client's assessments, yet are often told there is no one to deliver the care. When it comes to the macro level, poor staff retention is expensive. A rough estimate is that a turnover of one employee costs 1.5 times their annual salary. Existing staff are less efficient because they're constantly orientating new staff. Overall, morale decreases, which can lead to even further turnover, not to mention the amount of overtime costs required to meet the demand of existing staff.
In January, of 2020, I was asked by my director to lead a project to develop a framework to address CHW engagement and education. The first thing I did was ask for a CHW to co-lead this project with me, and Bobbi-Jo stepped up to the task. This visual shows the timeline and process of the project. So we began with a literature search to illuminate the evidence and determined a philosophy on which to build the framework. We then assembled a working group consisting of a range of stakeholders, including CHWs, home support managers, team leads, directors, practice leads, the home support transition knowledge coordinator, an improvement consultant, me, and my graduate student, who was Darien at the time. We developed a survey to gather data from CHWs about their thoughts and needs for engagement in education. We analyzed that data and identified action items from that data, including dissemination of this work. Excuse me. The philosophy we chose to support this work follows a people-focused approach. Liberating structures give permission and shift power structures from top-down approaches to community development, where innovation and transformation have a chance. Leaderful practice works within liberating structures and opens opportunities to challenge culture and the status quo. It supports a culture of investing in people wherever they work within the organization. It connects people and it breaks down silos. According to existing literature on CHW engagement, three main themes came to light. Often, CHWs have the most face-to-face time with individual clients, yet their expertise and firsthand knowledge of their clients is largely overlooked, excuse me, during care plan discussions. Many researchers called for increased recognition of CHWs as valuable members of the care planning team and argue that any barriers to effective communication be removed. They also called for intentionally designing CHW care assignments to promote more consistency. This would help both the care planning aspect and the client's experience. And unsurprisingly, many studies found that providing opportunities for recognition, feedback, and connection promotes job satisfaction, engagement, and retention. This could include creating avenues for clients and families to share their appreciation and positive feedback, engaging staff as leaders, or providing opportunities to share stories and celebrate their important work. When it comes to the education needs of CHWs, once they enter the workforce, research has identified three main focus areas. First, CHWs benefit from high-quality training, education, and supervision on specific topics. Although dementia education and experience is a requirement of basic CHW curriculums, caring for people with dementia in their own homes presents a unique set of challenges. In particular, CHWs must be prepared to manage responsive, resistive, and even aggressive behaviors in an environment where they lack access to the immediate backup of others. CHWs are providing care for those with complex and even palliative conditions with less access to support than they would in other care settings. So education on palliative care, symptom management, and working safely in clients' homes was a major theme in the literature. Second, researchers recommend that employers recognize efforts to develop new knowledge or skills with certificates or opportunities to be promoted into advanced positions. And lastly, it's recommended to deliver any formal education locally and in person with a focus on practical application, peer discussion, and interaction. Mentorship and apprenticeship models can help staff then consolidate those new skills in their actual work setting, which is client homes.
So all active CHWs in Interior Health were invited to participate in a survey to gain a deeper understanding of their perspective on engagement and education. The largest group of respondents were in permanent part-time positions, so about 62%, had 4 to 9 years of experience, and were between 45 and 54 years old. Of note, over 80% of respondents said that having enough knowledge and team connections helps them feel supported at work. Research has shown that supportive work environments contribute to reduced staff turnover, so it was exciting to see that respondents seemed to confirm that education and engagement strategies could contribute to improving staff retention. When it comes to engagement, you can see here that the majority of surveyed CHWs do not feel very connected or only somewhat connected to their workplace and their colleagues. I invite you to take a moment to reflect on your own workplace and situate yourself on these scales. CHWs shared heart-wrenching stories of feeling isolated from their colleagues and leaders, or of sharing a concern and being met with silence, dismissal, and even outright abuse. They describe being treated like just a number or the bottom of the healthcare barrel, and report giving up on engagement altogether. As mentioned earlier, many of these CHWs come from years of experience and a wealth of expertise. Some even described holding leadership positions in the past, yet being denied any agency when it comes to providing input and making change. From the survey, the top 2 preferred education topics reflect exactly what we see in the literature: palliative and dementia care. In the open-ended responses, 2 new themes emerged: a call for education on mental health, a call for more education on mental health, and an interest in learning more about how the health system works and the role of other professions within it.
Using leaderful practice principles, we look to CHWs to determine the path forward with tangible, people-focused recommendations.
When it comes to engagement, the goal for CHWs is to feel more connected, appreciated, and valued, not only with each other, but by the healthcare system team. Team dynamics improves as people get to know and trust each other. CHWs know important client-specific information, advocate for their clients, and they want to be acknowledged for what they know and what they do. Engagement amongst and with CHWs should be done in person, consistently, and led collaboratively. Like education, opportunities to engage must be protected, paid, and accessible. In practice, examples of engagement include routine huddles or team meetings, organizational development consultants to help guide cultural shifts, dedicated common spaces to help combat feelings of isolation and disconnection, team building activities to strengthen peer and interdisciplinary teams, and finally, consistent client assignment benefits CHWs, clients, and the wider healthcare team. Our survey showed that CHWs want to be able to confidently practice up-to-date techniques safely. Any new learning should be applicable to their work and evaluated in practice by supportive, accessible educators. Education must be practical and drawn upon diverse and combined formats. Ideally, all education needs to include hands-on, in-person learning. Effective and accessible CHW education must be prioritized, promoted, protected, and paid, meaning scheduled into work hours and protected from competing priorities. CHW respondents had plenty of ideas of how these principles can be applied, including integrating educational topics into existing team meetings or huddles, providing peer mentorship programs to support mentors to be willing and competent to providing high quality support and guidance, use monthly newsletters to summarize changes and updates, and consolidate learning through ongoing support and feedback in client homes where the work actually occurs. We all know recommendations are worth nothing without action. Many teams within Interior Health have done just that with great results. Some examples are I chair a monthly CHW community of practice to connect CHWs from across the health authority. This month will be our 8th meeting, our 8th community of practice. We've had much success with our meetings, including leadership to the group in respectful conversations of change. I like to use the catchphrase for CHWs by CHWs. The CHW group from 100 Mile House has been the leader in change to date. They have implemented many team building practices. These include a dedicated space, common space for CHWs to participate in education, practice skills, and get to know one another. You can see in the pictures of their practice dummy to the group participating in an all service about specialty mattresses. This space was intentionally placed within the health unit in order to promote interactions between CHWs and home and community care clinicians. This has significantly improved team building communication and collaboration. Education and engagement is also embedded into every team meeting, whether that's an in-service on naloxone kits, a meet and greet with home care nurse, or a guest speaker presenting on local Indigenous languages and cultural practices. The topics are identified by the CHWs according to their learning needs.
Poor staff retention in home health is detrimental to clients, CHWs, and the healthcare system as a whole. It's a complex issue with a series of interconnected solutions. Today, we've considered how evidence-informed engagement and education strategies can contribute to a more comprehensive and people-focused approach to staff retention. CHWs have supplied the contents of this strategy, and it is up to healthcare managers, administrators, and educators to align organizational structures to better suit home health clients and the hardworking providers who care for them. Improving team-based care is not just a suggestion, but an expectation from the highest levels of government when it comes to the design and implementation of our health systems. Some of our teams have already taken brave steps into this work by trialing team meetings or creating designated spaces for CHWs to connect and learn. It doesn't have to be perfect the first time, but the key here is to act with intention for the sake of our health systems, the healthcare workforce, and the clients and families we serve. And it looks like we even have time for questions.
Thank you. What an interesting presentation, to the confirmation of what we've learned so far, and hearing the voices of the healthcare workers through the presentation is really powerful. I'm curious about 100 Mile House and how they, is that space dedicated all the time? And how do they invite people into that space? Is it?
I'm just wondering if we have anyone from 100 Mile. Heather, are you on the call? Are you on the call at all? And I'm always hesitant to speaking for them, but I believe that space is permanent space, a dedicated space for community health workers.
I really appreciated the education driven by their needs. I thought that was really powerful too, and the topic sounded interesting already. I know the learning there's so much learning. I do have Kim says, this work is so timely given our older and aging population. Thank you. I wonder about the interdisciplinary collaboration component, and if these findings have been taken to IH senior leadership as of yet to impact good and well-needed change.
We do connect with leadership. However, we're battling culture and hierarchies, and I'm a nurse and I participated in that culture. I still do. I catch myself all the time participating, taking up that culture of hierarchy. So I think we're getting there, but you don't change culture easily or quickly.
Thank you for acknowledging that. That's a leadership move to acknowledge you are part of it and you're trying to change that, your own concept of it. And Barb says, how did you capture the learning in each iteration?
How did we capture
the
Not sure
learning
what you
in-
mean by that. So, you mean when people were trialing things at their sites?
Yes. Barb says yes.
Sorry. Well, we had a working group, and the people who were kind of piloting some of these ideas at the site would come to the working groups and then share what they were doing, and then the other pilot sites would then hear what they were doing and then maybe try to implement those things. And I haven't been involved in the community of practice, so I've been kind of out of the project for now, but I'm assuming maybe Bobbi-Jo, you can speak to that a little bit more about what's happening now. Oh, you're still on mute.
There we go. It's a sticky button. I apologize. We're about to enter our 8th community of practice. We recently have done some educational sessions, which is really important. Mary is a fantastic presenter who did incontinence, and I can't remember what exactly the teaching was.
Older adults, why are they different? Why should I care?
Yeah.
And it's not so much just for CHW's clients, but for themselves as well, for education. And then they've identified a number of other topics, like they really wanted to speak to the directors. So Joanna Harrison attended the community practice, and the CHWs had the opportunity to connect with those leaders and then ask those questions. And we all are also offering leadership positions to other CHWs to help Bobbi-Jo share the co-chair of that community of practice. And many of them have never been asked to do something like that before. Sorry, Bobbi-Jo, I could talk about this all day.
I just wanted to go back to another comment in the chat from Sue Jin. I'm assuming it's a she, maybe it's not. Anyway, is there a way to get involved as a volunteer? And I did put a chat, did you want to get involved in this CHW project? But they haven't replied. So is Sue Jin still on the call, and you want to, or was it something more general that you were trying to get involved in?
Hi. Yes, so I'm currently working as a pharmacist, and I was wondering if there were any opportunities, like in terms of trials or research, because I wanted to gain some research experience.
With this CHW project or in general?
In general.
Oh,
and
okay.
It can be specific as well. Like anything, really. I'm open to anything.
If you could reach out to us at the research at interiorhealth.ca email, and we'll definitely connect you up with people that work in that space in clinical trials, and we could have a conversation for sure.
Yeah, sorry, I didn't see that email on the group chat.
Yeah, it's there. I think it maybe not. It's just it's right at the beginning, and maybe it came on after. It's research at interiorhealth.ca.
Oh, okay, perfect. Thank you so much. Should I put an attention to someone specifically, or should I just mention my name?
I think the person who receives those emails on our call, and she will remember you.
You betcha. Okay. That's me. I'm Kim. I got you. Yeah.
Okay. Thank you.
So Barb, did we answer your question about capturing the learning and how we're moving forward there? Yes. Okay. Awesome. Any other questions for us?
There's one more from Shannon, and she said, I'm so impressed by this work and its outcomes. I'm wondering if there's a possibility or intention to translate this work to other program areas within IH.
Well, that's not something we've talked about for sure. It's already a big load of work for your big task right now. So no, but you know, a lot of the things that we've done are definitely, you know, translatable to other places. So if you have a place in mind that you want to do something like this with, we'd be happy to chat with you, but I'm pretty sure we're not going to take that work on.
That's fair.
But
I think that it's interesting. Our experience when we go into facilities and see teams is that the team is made up of all people on that. Like the knowledge is within, you know, we often have conversations with the operations team, with the janitors, with the people who are like, it's so interesting to me that how invested the whole team is if we can get them all engaged. There's power in that. And I love the little hair of Darien's little one there. I just have to say.
I just noticed that too.
A little rock star.
So I do want to say though that if you are interested in having quality improvement, an improvement consultant kind of support any improvement work that you want to make, there is a place on the Inside Net for you to request that support. So I can find that link and put that in there for you. But so when I say, you know, we're not doing that work, I'm just saying this group. But there is our improvement consultants out there who can help you. I'm not, you know, you're not on your own entirely. So let me just find that.
Thank you. I think that's all the questions we had. I appreciate the presentation. Thank you.
Thank you very much.
Yes. Thank you so much. And we will move to our next presenters.